All right, welcome everyone. Welcome to a Rafael Medina subspecialty episode. My name is Maddie, and I'm going to be facilitating the session today. Today's focus is infectious disease, and we have two just really amazing educators here who are going to make this session possible. So we have Dr. Uttara Gadde, who's an infectious disease fellow at Stanford, who's going to be presenting the case. And we have Dr. Dan Minter, who's an infectious disease specialist at UCSF and an early member of CP Solvers, who's going to be the case discussant. So super excited to learn from you both today. Thank you both for taking the time out of your super busy schedules to make this happen. And before we, dive into the discussion, just to briefly kind of hear each of your voices, would love to hear, what drove you to infectious disease, and if you have a specific interest within ID, would be super curious about it. So Dan, maybe we can start with you first.
Yeah, thanks again, Maddie, for having us. I'm really excited to be here, and CP Solvers holds a very special place in my heart. So it's really fun to come back and be working with you all to discuss a case. I love infectious diseases. I feel like they have the coolest. No shade to other specialties, but I feel like the ID cases are often really fascinating, really exciting, and the people in ID I think are just the coolest in my humble opinion. Interest within infectious disease, I attend on the transplant ID service mostly here at UCSF, and then I see folks in clinic for general ID, transplant ID, and then I see some neuro ID cases as well. Not doing a ton of HIV, so mostly kind of like gen ID and transplant ID though.
Amazing. Thank you so much, Dan, for being here. And Uttara, what about you? What drove you to ID? How was your first year of fellowship going? Any specific interest in ID? I'm so curious to hear.
Yeah, awesome. Thanks so much for having me, Maddie. This is so awesome to be here. I'm a huge CP Solvers fan. So yeah, I'm a first year ID fellow here at Stanford. And my primary interests in ID are global health related, as well as antimicrobial stewardship. So I'm trying to find a way to kind of marry those two things in the future. And first year of ID fellowship is great. It's really interesting. A lot of very cool cases, one of which we'll hear today. But it's definitely really tough. I was just saying it feels like a totally, steep learning curve. I feel like an intern all over again. But it's kind of fun to be in that position and just, have this year to learn and grow. And everyone's been super supportive, which is awesome.
Amazing to hear. Well, I'm super excited to learn from your case, as is everyone who is here. So I think we can jump right into it. Vinny, thank you. And I think actually Amal is here. So whoever of you wants to share your screen. And Uttara, when you're ready, you can go ahead and share the first aliquot.
Okay, awesome. So for this case, we have a 94-year-old woman who presents with one episode of a tonic-clonic seizure.
All right. Well, Dan, I know we have very limited information here, but I think it would be an interesting place to start. And as an infectious disease doctor, how do you think about a tonic-clonic seizure? And yeah, what's crossing through your mind right now?
Yeah. I think just trying to frame ourselves in like the problem representation, as we get more information about this patient, we'll learn kind of what this person, has in terms of contextual risk factors. And then we'll sort of begin to fill out, both the timing and then the nature of the syndrome, sort of thinking like the context, the timing, and then what syndrome. Mostly as consultants, we're coming in when there's more information, but this is certainly an interesting, tidbit of information that we're going to start to develop a bunch of hypotheses around. So what we can say is, this is an older person. I don't know where they're from, what sort of exposures they've had, but, certainly somebody 94 years old is potentially at risk for, infections that may reactivate later on as you get sort of immune senescence, like thinking of tuberculosis or something else like that. It sounds like the presentation is relatively acute with this sort of tonic-clonic generalized seizure. And then how do we think about seizures and infectious diseases, trying to borrow kind of a more general schema for seizures, thinking, is there something metabolic going on? Like, are we going to find out on labs that their sodium is, 115 related to SIDH2, that might be caused by like some sort of infection? is there, sort of an inflammatory or mass-like lesion that is going to be driving this? Certainly if this was like somebody younger coming from an area where, certain diseases are endemic, like neurocysticercosis, that's where my mind would kind of naturally go. But is there like a brain abscess? Is there, sort of a focal mass lesion that we need to be worried about that would be related to an infection? Are there some sort of toxins or sort of metabolic consequences of medications that we're giving this patient for an infection already? And then what else? I'd be interested if this patient had like a pre-existing seizure disorder. If it's a new seizure, then I'm certainly going to be more worried about, a mass lesion, a bleed, or something along that lines. So maybe, I'll pause here while we kind of wait for a little bit more information. But, certainly brain thing is at the top of my mind. And then things that can affect the brain are pretty numerous. And, in ID, we often, just go for a microbiologic schema whenever we're approaching a different syndrome of like, is there a virus that could be causing this? Like, viral encephalitis, HSV1, an arboviral encephalitis or something. And if that starts to become the case, we can talk about that more. Is there a bacterial cause? Most of the bacteria are either going to be meningitis or brain abscesses. Is there a fungal cause? Certainly, fungal meningitis or fungal brain abscesses are possible. And then, parasitic causes are also something that could be considered. Certain parasites have neurotropism, like neurocysticercosis, like I was mentioning. So I would say that the microbiologic differential is one of the things that you can kind of rely on in infectious diseases as you start to build a schema as you're interested in approaching any sort of syndrome. So maybe I'll pause there. There's a lot of things it could be, and we can get a lot more specificity and kind of speak deeper about the ID related causes as we go forward.
Yeah, that was absolutely brilliant. Thank you so much for starting us off in that way, Dan. And Uttara, we'll pass the mic back to you to get some more information.
Sounds good. So some more information. So this patient was primarily Vietnamese speaking and preferred to use her son as her translator. So all this information was from her son. She said that she was in her usual state of health until yesterday when she was laying in bed and suddenly felt like she, quote unquote, left her body. She does not know how long the sensation lasted, but she notes that she was confused afterwards. She also notes that she wet her bed during this episode. She does not recall anything like this happening before. According to her son, who witnessed the event, she suddenly developed jerking motions of her bilateral upper and lower extremities. She was unable to respond when she was called and was not tracking with her eyes. The episode lasted for about 1 minute and self-resolved. She has never had an episode like this before, according to her sons. In terms of other relevant medical history, she does have a history of relatively recently diagnosed breast cancer, notably right invasive ductal carcinoma, which was diagnosed in 2023. She had a PET scan done earlier that year with metastases to several bones, as well as the hilar lymph nodes. She's been treated with anastrozole, and further chemotherapy was not pursued given her age and the potential significant toxicities. She did have an interval repeat PET scan after starting anastrozole therapy, which showed a reduction in the right breast tumor size. In terms of her current medications, she's on anastrozole, amlodipine, and rosuvastatin. She has no known allergies. And in terms of her family history, she has an aunt with breast cancer who's now deceased. And then I'll also give a little bit about her social history. So she was born in Vietnam. She moved to the US in the 1980s. She's been back to Vietnam 4 times since then, most recently in 2020 when she was visiting family. Her family lives in an urban area in Hanoi, and she spent most of her time in the family home. She eats meat regularly, but did not make any direct contact with animals. She did not spend any time near water bodies. She has no pets at home. She does not smoke cigarettes, take any drugs, or drink alcohol. And I'll stop there.
Amazing. Thank you so much, Uttara. And Dan, we got a lot more information here. And, we started with the tonic-clonic seizure, and I'm curious how the past medical history that we learned and some of the social history, how is that influencing how you're thinking about the case?
Yeah, and maybe just one clarifying question. Uttara, you might have said this, like what was the time relation with the PET scan to her current presentation? Was it like several months ago? Was it a week ago?
Her most recent PET scan was in September of last year. So
And
September.
when she presenting now or?
She's presenting now, yeah.
Okay, gotcha. So, well, again, kind of going back to our, formula for the problem representation that's going to guide our thinking is like context, timing, and then the syndrome. I'm going to put a pin in the syndrome because, we're still kind of at the symptom level description of it. I think once we get, brain imaging, that's going to be a large branch point for me of like, is there a mass lesion? Is there not a mass lesion? And then also, interested in like LP and stuff like that. But sort of filling in like the other two components of like the context and the timing. The context, there's several things here that are interesting. Certainly, coming from, a country like Vietnam, there are different infections that you need to worry about that could either, be acquired during travel or reactivate from her prior residence in that region. Especially as you get older and have sort of an immune senescence just kind of with age, and then also, the medical illness with her metastatic breast cancer. Obviously the big thing that people are always going to worry about is tuberculosis. Somebody who's in their 90s coming from an area where it was currently endemic, but, was likely more endemic when she was growing up. That's something that can reactivate decades down the line and, needs to be a consideration, both from the perspective of, a public health concern of, is she going to be contagious and spread it to others? And then also if it is like a CNS related infection with tuberculosis, the morbidity and mortality of that is going to be really, really pretty dramatic, especially in somebody her age. Other just kind of random things to think about, in somebody coming from Southeast Asia. We don't ever see it with much frequency, but, on like the ID boards, you're asked about like melioidosis, it's Burkholderia pseudomallei. It's like a non-fermenting gram-negative rod that is interesting and can be like a TB mimic, but also is the possibility of reactivating, years after initial exposure. They would see that Vietnam veterans coming back, after the Vietnam War to the United States could reactivate with this infection up to, I think, like 30 years down the line. Beyond that, I don't think that it's super likely to reactivate, but it is something to consider. Often is like a sepsis picture can be like a indolent pulmonary sort of picture, and then also spinal osteomyelitis sort of picture. Other things in that area, are possible. We can think about like Taloromyces marneffii, but that's going to be more in the context of folks living with HIV or other sort of dramatic forms of immunocompromise. It's a dimorphic fungal pathogen that's found in Southeast Asia. There's other sort of like a variety of parasitic diseases that can be found there as well. But in terms of things that can reactivate, I think, TB is always going to be a major concern, especially in somebody in their 90s coming from an endemic area. Other stuff that we were told about, going back and forth, when you think about like fever and returning traveler, there's this term called like BFR, visiting friends and relatives. So folks who have family in areas, that are endemic to certain infections may take fewer precautions in terms of, prophylaxis, like malaria prophylaxis. And they see that epidemiologically, folks who are going back to visit family are more likely to come down with, certain travel-related diseases like malaria, because, maybe they grew up in that area, they never took prophylaxis before. Why take prophylaxis now? The breast cancer, we talked about travel, we talked about like residents in, countries outside of the United States that could have different infections that we don't see all the time. Other things, she's also, of quite advanced age and has like metastatic malignancy and is going to be, relatively immunocompromised compared to the general population. So we could see things that, maybe more typical organisms that are going to have a more severe presentation in her. So again, getting back to our framing around the seizure, like what are things with neurotropism, a variety of bacteria, strep, staph, some gram negatives, viruses. We have a lot of neurotropic viruses, specifically HSV, VZV are, known to reactivate, come back to the CNS. And then, other things, if this is a case that's presenting, I guess, since you started ID fellowship a month and a half ago, so this is a presenting over the summer, things that happen over the summer that are of neuro relevance are going to be like, the viral causes of encephalitis. So I think of those as like the herpes viruses, the arboviruses, so things that are arthropod borne. Here in California, we do see West Nile, we do see St. Louis encephalitis, especially during the summer when the mosquitoes are more out there. Other things that you can see is like enteroviral meningoencephalitis, and that can just be kind of community acquired and doesn't have the same predominance only in the summer that some of the arboviral things will have. There's not going to be a whole lot of like community acquired parasitic diseases that she's necessarily at risk for. And then fungal stuff, if you're here in California, we worry a lot about coccidioidomycosis, especially if they've had residence in the Central Valley or traveled to the Central Valley. This is something that, it's a dimorphic fungal infection we see, in the United States, in the Southwest states, so like California, Arizona, New Mexico, and then some in Texas, and then like throughout Central America. It tends to be not as fulminant as what you're describing, and is more of a chronic meningitis sort of picture. So obviously, if she had no symptoms or very few symptoms leading up to this, I would be less concerned about cocci, but I'd probably send a test, pending how this sort of shakes out. So that's a lot of talking about like risk factors from the limited information that you've told me. I think that we're going to get to a big inflection point of like, is there something on imaging or is there not something clearly on imaging? And then, I'm really interested for CNS infections of, likely analyzing the CSF, where you can get a lot of sort of clues about what sort of pathogen may or may not be involved there as well. I think I said most of what I wanted to say. I'm not sure if I missed broad parts, but I'll pause there.
I think you missed absolutely nothing. That was amazing, Dan. I just had one quick question. So you talked about some of the bugs that can reactivate. You mentioned tuberculosis, melioidosis. I was just curious, kind of at a high level, how do you think about what factors increase someone's risk for reactivation of a previous infection that was more dormant? Like what factors, is it medications, immunocompromised state? Like what factors increase one's risk to have a reactivation of a previously dormant infection?
Yeah, I think of your immune system. You don't necessarily have to have like a diminished immune system to reactivate with TB or HSV encephalitis, for example. But the immune system is important for ongoing immune surveillance. And as you age, you do get sort of some degree of immune senescence, and people will have higher propensity to reactivate certain infections. Exogenous immunocompromising factors, like if this person, she's not going to get an organ transplant at 94, but like if she did get an organ transplant and then was on, immunosuppressant medications, that can cause a higher risk of reactivation of things that were acquired pre-transplant. And then, I think probably most relevant in her case is going to be, the metastatic breast cancer. She has like a severe systemic medical illness. One thing that I didn't mention, but like outside the realm of ID, obviously, is like, if you have metastatic cancer, now you have CNS stuff, thinking like, are there CNS mets from that perspective as well? But, I think of anything that sort of affects the immune system, would be a factor that could have some sort of influence on whether they're going to reactivate with a previously acquired infection.
Thank you. All right, Uttara, back to you.
Okay, awesome. Thank you so much. That was amazing. So more information. So in terms of her vitals, she was afebrile, her temperature was 97.1, blood pressure of 125/68, respiratory rate of 15, heart rate of 55, satting at 100% on room air. In terms of her physical exam, she was generally well appearing and no acute distress. Her heart sounds were normal with no murmurs. Her lungs were clear to auscultation bilaterally. Her abdomen was soft, non-tender, non-distended. In terms of her neuroexam, she was alert, awake, and oriented ×3, which she's at baseline. She had 5 out of 5 strength in her upper and lower extremities bilaterally. She had a normal finger to nose test, normal rapid alternating movements. She had a negative Romberg, and she had normal sensation throughout. In terms of her labs, she had a white count of 6.9, 62% neutrophils, 23% lymphocytes, and 2% eosinophils. Her hemoglobin was 11.9, platelets of 227. Her sodium was 141, potassium of 3.6. Her bicarb was 26. Her glucose was 112. She had a BUN of 15, a creatinine of 0.74. Her alk phos was 77. Her AST was 24 and an ALT of 16. And then they did get some initial infectious disease labs. She had a negative HIV. They did a Hep C screening, which was negative. Her quant gold was negative. They got a strong IgG, which was negative, and serum Cox antibodies, which were negative. Unfortunately, the patient did not want to get an LP, and so that was not obtained because that was not within her goals of care. But we did get an MRI of her head, which I think I'll go ahead and share now. So they got an MRI of her brain with and without contrast, and the read showed punctate subacute infarct in the right posterior caudate body. Also, a 4 millimeter right frontal and 3 millimeter left anterior cingulate rim enhancing lesion with no significant perilesional edema. Finally, there was a punctate enhancing focus in the cisternal segment of the left trigeminal nerve, and I'll stop there.
All right, Dan. So very curious to hear kind of if anything stood out to you in the physical exam and the labs, and then of course in the imaging. Very curious how you approach rim enhancing lesions.
Yeah. Sorry, and Uttara, just to confirm, there was like 3 or 4 lesions. They're all less than a centimeter. A couple of them are rim enhancing on gadolinium.
That's correct, yes.
Okay, gotcha. Did they comment on like diffusion at all, or?
They did not. All they said was that there was no significant perilesional edema, and that's it. That's the only thing on the MRI read.
Okay, awesome. Well, I think that this is interesting, and I'm getting increasingly intrigued by the case as we go on and get more and more information. I would say that just kind of going through the information presented so far, like not a whole lot of signal on the vitals, not a whole lot of signal on the exam. If I'm interpreting correctly, it seems like a relatively normal neuro exam. And then, on our labs, like ticking through like the CBC, we're not seeing like a crazy leukocytosis with, eosinophilia or anything that's going to really draw my eye. And then on the other sort of testing that we have, I think it's of relevance that the HIV is negative. That's always going to be a major branch point in terms of like, what's this person at risk for and not. Quant gold, just speaking broadly about tuberculosis, something in the order of like 20% of folks with active tuberculosis will have a negative quant gold. So it doesn't sway, the risk of having active TB dramatically. And the strongy, is interesting. I didn't think that this was going to be strongy necessarily, but it's good to have that there. So getting into the MRI, I've been holding my breath for imaging this entire time. So I think, this is going to provide a lot of clarity of what our syndrome is. So we went from seizures now to multiple sort of non-contiguous, comparatively small ring enhancing lesions without surrounding edema. What does ring enhancing really refer to? It's going to be some breakdown of the blood-brain barrier around the lesion. I was asking about diffusion weighted imaging. So diffusion weighted imaging is something that's often brought up for like, stroke evaluation, and it kind of, describes the movement of water molecules. So if you see it restrict diffusion, in the context of a stroke, it's like, okay, those cells are dead. From an ID perspective, rim enhancing, a thin sort of homogeneous rim enhancement with centrally restricted diffusion is something you might see with like a collection of pus. So if you have pus, it's acellular material. You're not having water molecules really, diffuse across cell membranes. So it restricts really heavily and is kind of like a tip off for bacterial infections. So, if we focus our mind more around the idea of like several, rim enhancing lesions that maybe don't respect like, they're not like all right next to the external ear, trying to think of like mechanisms of how those lesions got there. They probably didn't crawl from a particular structure and are more likely to be, something that was arriving at the brain through a hematogenous route. What things could be in that sort of bucket? So thinking microbiologically, is this like a great story for a virus? Probably not, unless, there was like some infarct that then, we're seeing enhanced, like in the context of VZV vasculopathy or something like that. I'd say broadly, more viruses are not going to cause you like rim enhancing lesions, classically. So virus is probably less likely. What about bacteria? Can you have multiple bacterial brain abscesses? Absolutely. And the scenario where that's going to be more likely to happen is through a hematogenous bloodstream infection. So like if you have endocarditis or like, staph bacteremia with like metastatic foci, like could you have multiple small ring enhancing lesions there? I think that that's a possibility. And, that's going to be something that I maintain on my differential diagnosis. What about fungi? Fungi could do this. Things that are common, fungi that have neurotropic properties is going to be like Cryptococcus. That tends to be more of a meningitis picture, but you can get cryptococcomas. Could cocci do this? Probably, but again, cocci is overwhelmingly like a chronic basilar meningitis picture with or without strokes that are involved, but you can occasionally get fungal brain abscesses from cocci. Is this, maybe taking a step back for fungi, I kind of think of like yeasts, dimorphics, and molds. So yeasts, I mentioned crypto. Candida is not that big of a deal for brain stuff without the context of neurosurgery. So crypto is overwhelmingly the thing there. Dimorphics, we mentioned cocci. There is histo here. There's probably histo in Vietnam. Probably not blasto out there, but maybe something that I might test for is like histo. And then in the monomorphic mold category, it's like, Aspergillus, Mucor, and then kind of rare molds typically. Those are something that are possible, but less likely. They're more problems of folks with very profound immunocompromise. But anyway, fungal is possible. And then, the parasitic side of things, is this like a great case for neurocysticercosis? Probably not, since you're not saying like calcified lesions or areas of cystic lesions. You can get rim enhancement of small fluid-filled lesions in neurocysticercosis. It's a relatively characteristic finding on MR, so you should be able to, I would imagine that the neuroradiologist would call that out if they were particularly concerned about it. What about other weird things? Kind of thinking of like more unicellular organisms like toxo. Toxo has a predominance of CNS lesions, and we classically learn it in the context of HIV, but it can happen in other contexts, like folks with hemolignancies or even solid tumors. I imagine it could happen in that. Generally, something that's going to be more common if you have more profound immunocompromise. What else? Unlikely to be other helminth infections. Amoebas is one of the other things that we talk about. I think a lot of folks learn about amoebic meningoencephalitis in the context of like Naegleria, of like a kid who swims in a river or swims in a lake and then gets like overwhelming CNS infection. That's the sort of primary amoebic meningoencephalitis that's very, very fulminant. You can also get granulomatous amoebic meningoencephalitis from Balamuthia mandrillaris, and then for folks who are more immunocompromised, something called acanthamoeba. And that can also present, both of those are hematogenously disseminated to the CNS, and they can present with like multiple small rim enhancing lesions and are relatively challenging to treat. There's pretty poor mortality with all of those. And there's unclear guidance on what treatment is. So what do we do now? I think functionally, if LP is absolutely not possible, then we're kind of stuck with serum studies. I know here at UCSF, we would probably send this for a plasma metagenomic sequencing, so like a cell-free DNA test of the plasma to try and hopefully pick up if this is a disseminated infection. Stuff that would, you would find potentially affecting the CNS. Blood cultures are going to be a great, cheap initial test that, I imagine were sent. Is if this is something like endocarditis, getting an echo. You could do a variety of other sort of serum tests depending on like the exact character of the lesions when you talk to radiology. you'd send a plasma or a plasma toxo PCR. You could send, I'd probably, yeah. I mean, you had COX-C stuff that you sent. What else? A CRAG is an easy test to send that comes back really quickly. Yeah, so functionally, I would be walking to the neuroradiology reading room and, talking with them while we wait for the blood cultures to cook. And if the blood cultures are positive, that's going to be a relatively more straightforward path to our diagnosis. If they're negative, then I would be hoping to get some sort of invasive sampling, but, I agree, somebody who's 94, they're probably not going to want us to aspirate one of these lesions. Other things, just random rim enhancing things, Chagas rarely can do it. In immunocompromised folks, you can get a rim enhancing lesion. I think that's more or less, I'm going to pause there. I could keep blabbing for a while, but that's kind of where I would start. Probably not viruses, bacteria. Hopefully we find something on the blood. Fungi, we have some non-invasive testing. Parasites and amoebas, those are a little bit harder to diagnose, but, you could get there either through the plasma or maybe if we're going to get like a CNS biopsy or LP or something like that.
Yeah, that was such a thorough differential. And I just wanted to go back to, you were commenting on the different kind of characteristics of like descriptions of the MRI lesions and how they would help you make progress, like the ring enhancing, the diffusion restriction. I was curious if there are any specific findings on MRI that you look out for to help make progress. For example, you mentioned calcifications. I'm curious, besides neurocysticercosis, like how would calcifications help you?
I think neurocysticercosis would be like the most classic disease association. Like if there was calcifications, like, calcified nodules in the chest image, that's another thing we could do is we could get chest imaging. Oh, I totally forgot like a whole nother category, like weird bacteria. There's regular bacteria and then there's weird bacteria. So like nocardia is something I would bring up. Actino is something that can rarely happen. And then, we've danced around mycobacteria. So could this be TB? Anything, TB can do anything. But anyway, sometimes with a brain infection, if you're unable to access it there, you might look for extra CNS manifestations of disease that are potentially easier to get at. So, certainly a chest scan, I think, would be helpful, and then maybe a chest, abdomen, pelvis. Back to your original question of calcified lesions, like if there's a bunch of calcifications all over the place, that's like building a stronger case for neurocysticercosis because the lesions undergo kind of evolution and end in this sort of final common point of like scarred down calcifications. That can be hard to see on MR, not impossible to see on MR, but harder to see on MR than CT. And then, I think for granulomatous diseases, the sequelae of old granulomas can end up being calcified lesions.
Amazing. Thank you. All right, Uttara, back to you.
Okay, awesome. So just a couple, more pieces of information. So she did get an echo, which was unremarkable. She had a chest X-ray, which was also normal. She had blood cultures that were drawn that were pending. And just like you said, we made the walk over to neuroradiology to talk to them a little bit more about the imaging findings. And they felt really strongly that these lesions actually represented metastases, so that they felt that her cancer had progressed and she now had brain lesions. And so we kind of communicated that back to the primary team, and they got radiation oncology on board. So as part of kind of prepping for radiation therapy, she got a CT head, which showed multiple calcifications without surrounding edema. And the radiologist recommended a repeat MRI for further characterization. So I'll kind of stop there and just see what you think about this discrepancy between the MRI we just got and then the CT head we got for radiation planning purposes.
Yeah, like on the MR, it can be hard to see calcifications. I don't have it off the top of my mind, but there are certain sequences that can be more sensitive for calcified lesions on MR than CT. CT is very easy to see calcified lesions, and again, sort of suggests that there's a burnt out, often related neurocysticercosis, but again, could be like any granulomatous infection, especially if it's outside of the CNS. So if this is basically, like if it is neurocysticercosis, it's something that can be pretty characteristically established on imaging with a combination of a CT and then an MR. If they're repeating the MR, they sometimes do something called like a Fiesta sequence that has better sensitivity for neurocysticercosis lesions. Um, let's see, there are serologies that could be helpful, like as a rule-in test. The ones that most people are able to order at their institutions are actually the wrong ones. So like the ELISA test that you order for neurocysticercosis is like actually not that sensitive. And like half of the neurocysticercosis cases I see in clinic like have a negative ELISA. The better test is the enzyme immunotransfer blot test. That I think is mostly a send out test. I think you can do it at Quest, but a lot of the time it's at CDC. Does a bunch of calcified lesions mean it's absolutely neurocysticercosis? Probably not, but that would be like the #1 disease association with like rim enhancing lesions and a mix of rim enhancing lesions and calcified lesions. So what happens in somebody who has neurocysticercosis is that the lesions go through like several phases. Like the sort of active growing lesions have very little edema and are sort of immunologically hidden from your immune recognition as they grow. Once they start to die and break down, you then get like this blood-brain barrier disruption. And that's where you get enhancement. So like rim enhancing lesions. That then like often spills like cyst contents into the surrounding brain and they get a fair amount of edema, and that's kind of when you have seizures. I think one of the things that's interesting about your case, Uttara, is that you mentioned there's not a whole lot of surrounding edema. A lot of the neurocysticercosis cases I've seen have had like a fair amount of edema, especially in the context of these degenerating cysts. They don't always need to, but they often do. Anyway, then over time, the cysts kind of like collapse on themselves and then will scar down into a calcified lesion. And that calcified lesion can be a focus of seizure activity going forward. With this person who's 94, I'd be interested in, have they had seizures throughout their lives? Because that tends to be the case when somebody has like a high burden of disease. You can do a PCR test off CSF, and there's an antigen test that can be sent off either blood or CSF. But yeah, I guess other things, that's really the #1 thing that you tend to see with calcified lesions on the brain. But I'm intrigued about where this is going to go and if we get more microbiologic information. The neuroradiologists, part of practicing medicine in a team environment is they're often really, really helpful. Sounds like in somebody with metastatic cancer, like the pretest probability of something being cancer related is going to be high, but going back and then sort of saying like, hey, with the context of like these multiple calcified lesions, what should we be thinking about here?
And Dan, would you say that this patient is a typical host for someone who gets neurocysticercosis? Do some of her risk factors align with those that you've seen in prior cases?
I will say most of the cases I've seen have been from Latin America, and a lot of them are young. She would be like more on the older spectrum from what I've seen, but there are cases certainly throughout Asia, and it's mostly related to close residence with pigs, and being exposed to pig feces and that sort of environment. I'm trying to think of like, are there other things we should be thinking about? There probably are other things we should be thinking about, but that's a very common disease association, and it happens outside of Latin America for sure. I think fungal infections can calcify. Like histo classically calcifies in the mediastinum, but I haven't really heard of like CNS histo calcifying like that. And I think one of the other interesting things is like her seizure, her presenting symptoms were like episodic. She's like back to normal right now. So a lot of the other sort of infectious things, that we tend to think of as like, causing these more chronic or subacute pictures, like she shouldn't be all the way better. So I think that like seizure related to a mass effect from one of these things is going to be, probably the way we get our diagnosis.
All right, Uttara, back to you. What happened?
Awesome. So we went ahead and repeated the MRI brain, this time with Fiesta sequencing. And the read showed numerous, greater than 20, cerebral calcifications, most of which do not demonstrate enhancement, although lesions along the right precentral gyrus, left orbital frontal region, and left cingulate exhibit peripheral enhancement. Furthermore, there are small cystic lesions within the left sylvian fissure, one of which has an enhancing mural nodule.
So I would say that sounds more like neurocysticercosis. And then the Fiesta sequence has better, I think the reason they use it has better spatial resolution for subarachnoid disease. So basically when you have neurocysticercosis, you try to put it in, one of several buckets, parenchymal lesions, interventricular lesions, and then subarachnoid lesions. And parenchymal lesions, like if there's just a couple in the brain parenchyma, those are the easiest to treat. Subarachnoid disease, which this seems like it's going to be the case, especially with all the lesions along the sylvian fissure, is much more challenging to treat, and you end up doing very, very prolonged courses of combination antiparasitics with steroids. And it's like unclear like what sort of parameters you should use to stop antiparasitics in those cases. Standard treatment is going to be with albendazole and praziquantel in conjunction with high dose steroids, because so much of the disease process with neurocysticercosis is related to the inflammatory effect. And specifically with subarachnoid diseases, you get like, such a robust inflammatory response in the sort of subarachnoid space, the meningeal space, that, you can get scarring of the meninges, you can get, development of like a CSF block, you can get development of like a CNS vasculitis as you kind of like pinch off like the penetrating, CNS vasculature with scarring. And, it can be very, 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 catastrophic disease to treat. Intraventricular disease is also like I can't remember if you said she had an intraventricular lesion, but it's like a very challenging one to treat because you can get, if it scars down kind of within the pathway of like CSF flow, you can get hydrocephalus and like a block in communication of like the CSF flow. So that's something that, is quite challenging to treat and maybe an indication for like, ventricular endoscopic surgery to try and remove some of these lesions. But yeah, I mean, at this point, even if the serology is negative, I would still think that that neurocysticercosis is like far and away the top of my differential. Since she does have subarachnoid disease, if she were willing and interested, an LP could probably be informative. But with this burden of disease, you might be able to find it on a serum antigen as well. But certainly steroids, I think, before you start treating, and then a very prolonged, like probably more than a year of antiparasitic therapy is how this would be treated. But again, that's going to be couched in like, what's this patient's goals? What are they hoping to do? And like, this is a long, challenging course for this patient.
If I could ask one quick question before we hear from Uttara, I'm curious, does neurocysticercosis mainly kind of only affect the brain, or are there extra, common extra neuro symptoms of neurocysticercosis?
Yeah, it can go anywhere, but like it doesn't cause problems that much when it's not in the brain. It's mainly that the brain is like a really sensitive organ, and like inflammatory sort of inflammation while the cysts degenerate can cause a lot of havoc in the brain. You can often pick up, calcified lesions in folks' muscle, like if you x-rayed their leg or something. I think there's like a New England Journal image where if you Google it, like cysticercosis, like in the muscle or something, you can definitely see like lots of little flecks of calcified lesions in other muscular beds. It kind of like ends up in your brain, like, I'm not gonna say by accident, but like, it's everywhere else too, oftentimes, and it causes the most problems when it's in your brain.
Yeah. All right, Uttara, what happened next?
Awesome. So we sent out a confirmatory test, which clinched the diagnosis, and that was cysticercosis IgG Western blot, which came back positive. And so we diagnosed her with neurocysticercosis. And I don't know if you're going to talk about this, Dan, but in terms of treatment planning, we sent her for screening optho exam, which we do kind of because there's such a large inflammatory response that happens when you start treatment for neurocysticercosis. You want to make sure that there's no kind of retinal lesions because people can actually go blind from the inflammation. And so we sent her to optho. Her right eye exam was normal. Her left eye showed an inner retinal hyperreflective lesion with small cystic spaces. And the ophthalmologist wrote in their note, these findings are concerning for ocular cysticercosis. So I'll stop there.
That's not good. That's pretty crazy. Yeah, I have not seen anybody with ocular cysticercosis. I have a couple of folks in clinic that have like neurocysticercosis. That's a great point that you need to screen for ocular disease. I can't remember if there's like a recommendation for surgical excision of the cyst. There might be for ocular disease. Because certainly with any ocular infection, you worry about, drug penetration into that space. And it's kind of like a privileged space that drugs don't get into particularly well. And I would talk to my pharmacist about this and go back to the cysticercosis guidelines. And it's a high consequence space of like, if there is an inflammatory response, like you said, Uttara, like they could go blind or, have awful consequences to their vision. This is the sort of disease process too, where you're really going to be asking for help from national experts, either NIH or there's a number of experts, locally and then kind of nationally, that this is a bad case of neurocysticercosis, and I wouldn't want to be managing this entirely by myself by any means.
And before we kind of pass the mic to Dan to hear any teaching points he wants to emphasize, Uttara, I really wanted to hear any reflections that you have about what it was like taking care of this patient and if there was anything you learned that you wanted to emphasize.
Yeah, no, that was amazingly done, Dan. Thank you so much for that. And this was such an interesting case because, this woman with metastatic brain cancer is coming in with new seizures and has this MRI that, convinced even the radiologist that there were new metastases. And she's literally about to get radiation. And then we get this finding on the CT, which completely makes us change course. So that was a very, very interesting kind of plot twist. And I think, the things for me that were really interesting, I learned a lot about neurocysticercosis. It's 1/3 of all new adult onset seizures in the world are because of neurocysticercosis. So it's something that, we should really know about, especially working with refugee patient populations or in the global health setting. And I also thought it was really interesting that it's kind of a disease of many different phenotypes. So it's hard to kind of lump it all into one sort of, characteristic presentation. And it really depends on many things, including kind of the host inflammatory response. It depends on the burden of disease. And like Dan was saying, it totally depends on the location too. And all of those things kind of in conjunction are going to determine your kind of treatment planning moving forward. Including whether or not this is live disease, right? So whether or not these are all calcified lesions or, live cystic lesions where you can actually see the scolex, because that's going to determine whether or not you're even giving antiparasitic treatment versus, just giving steroids and, symptom management with anti-epileptic medications. So it's a really, really complicated disease. And I think kind of going through that thought process was really, really interesting. And like Dan said, there's some experts in this at NIH. And so we were able to consult with them as well to see what they would think. And I think the most interesting part of all of this was the ocular lesion. So that's like exceedingly rare. There's case reports really only in India of ocular neurocysticercosis. So this was, a really unexpected finding. And like Dan was saying, before we start treatment, we'd actually have to surgically excise that lesion. And so That was something we discussed with our patient, and she was absolutely vehemently against that. And so I think, the last thing I'll say is taking into account kind of the real world situation. So she's 94 years old. She has no interest in undergoing prolonged therapy with multiple antiparasitic agents. And I'll say that because she had so many cysts, so in patients that have like more than 3 cysts, we usually do dual therapy with praziquantel and albendazole because they have better outcomes. So she would be on both antiparasitic agents for, at least a year, plus really high doses of steroids because she has extraparenchymal disease. And so between that and having to have, the eye lesion removed, she was like, absolutely not. And so what we're actually doing is just kind of monitoring her in clinic. And we talked about, if she does have another seizure, potentially treating her with anti-epileptic medications just for kind of symptom management. So yeah, it was a really amazing learning case. And, you discussed it so beautifully. So thank you so much for that.
Really, really fascinating case, and like just a great example of, really devastating disease that was a hard diagnosis to arrive at, and somebody that maybe isn't the picture that a lot of people have in their minds of who's going to get neurocysticercosis. So it's a good reminder to like have it on your differential for a lot of folks.
Yeah, Uttara, thank you for that teaching. And it's really kind of inspiring to see both diagnostically how much work your team did, but also kind of understanding what the patient's goals are and kind of meeting the patient where they were. So really wonderful teaching. And Dan, before we end the session, I'm wondering if you have 2 or 3 teaching points you wanted to highlight for everyone listening.
Ooh, I feel like Uttara had so many good teaching points. I'm
Yeah.
not sure I can really add on top of that, but yeah, I would just co-sign everything she said. So.
Sounds good. Sounds good. Well, Dan, truly phenomenal discussion. The way you built a differential and your specific teaching points on how nerve cysticercosis can present was very amazing, and I learned a ton. And Uttara, thank you so much for preparing this really educational case and very powerful reflection at the end. So thank you both so much. I think we all learned a lot this session and really appreciate you taking the time.
Thanks so
Awesome.
much.
Thank you so much.
Bye, everyone.
Bye-bye.